Good afternoon and welcome to today's program titled 2018 CMS Policy Preview, New Quality Measures, Possible Repeal of Therapy Caps, and more. I'm Pamela Tabar, Editor-in-Chief of iAdvance Senior Care. Our program today is sponsored by Omnicare, so thank you to our sponsor and also to you and our audience for joining us today. Before we get started, we have a few housekeeping details I just want to go over with you. Please use the Q&A area below the slides to submit a question or a technical issue at any time. You don't have to wait until the end of the program to submit any sort of question. To download a copy of the presentation, you can click on the link in the Resources tab, which is to the right of your slides. A special note about CE credits. To get your CE, you must watch the program all the way through the Q&A section at the end of the presentation. So when the presentation is over, don't leave the site. The site will automatically redirect you to your certificate. For those who are watching in a group today, please download the group submission guide in the Resources tab and follow the instructions provided. Please note that CE credit is only available for today's live event. It's not available for the archived version of this webinar. And finally, you can join the conversation on Twitter by tweeting with hashtag IASC Live Webinar. At this time, it's my pleasure to introduce today's speakers. First, Cynthia K. Morton is a national expert on Medicaid, Medicare, and other public policy affecting the long-term and post-acute care sector. She serves as the Executive Vice President for the National Association for the Support of Long-Term Care, also known as NASL, where she advocates for her members' interests. Also today we have Nancy Losbin. She's a consultant pharmacist and the Chief Quality Officer at Omnicare. So thanks to both of you, Cynthia and Nancy, for taking time out of your day to speak with us today. And Nancy, why don't we get started with you and you can take it away.
Well, thank you, Pamela, and good day, everyone. I'm excited to be able to participate in a discussion on such an important topic. So we're going to move along right into our next slide as we discuss whether medications in long-term care are a help or a hindrance to achieve full potential in rehabilitative and restorative services. A study was done that looked at over 11,000 residents in 945 nursing facilities, and these patients were studied for 5 years. Their admission diagnoses included primarily stroke, hip fracture, COPD, heart failure, and some other diagnoses. Rehabilitation services were provided to 58% of the patients reviewed, and the residents who received rehabilitation services were 48% more likely to be discharged to home. The risk of death in the first year was lower by 19%, and the relative risk of discharge back to the community improved 3.6% for every single hour of therapy received. This is quite an impressive study and really drives the importance of rehabilitative services in long-term care facilities and that service that we provide in high quality to our clients and customers. When you take a look at this next slide, achieving the highest practicable well-being, you see that it fits right into our dictates from the State Operations Manual. If you look at the diagram in the center, you'll see maximum success, certainly centered on the resident or the patient. In the corner of the square, you'll see, first of all, the consideration and care planning approaches for the outlook of the patient. Are they embarrassed by their new loss of functionality or perhaps depressed over it? A resident who was dancing last Saturday night at a wedding might have had a broken leg or has suffered a stroke, and this Saturday night, they're in a rehab center with you. They may be very anxious about recovery and if they'll ever be the same again, and some of them just give up hope and are not really motivated to participate fully in rehab. So we need to take a look at the lower right-hand corner and the resident's ability and their willingness to perform. while in the other corner we look at their nutrition to assure that they have the energy to complete their rehab services and that they are not chemically imbalanced that would cause them to either be tired or be able to participate in fewer numbers of units or minutes in rehab services. And then most importantly, these residents who are in new ADL levels need to find rest that is not only comfortable, but they need to sleep well. On the north, south, east, and west of this diagram, you will see the ethical dilemmas. When do I discharge a resident? Who is to say that a resident can no longer perform to their maximum ability or achieve the next step in rehab services, and then we would discharge them? There are certainly new reimbursement issues that have to be considered to assure that we meet the more than minimum number of minutes to assure we get the highest level of reimbursement for the services provided. And that comes along with the regulatory compliance in the patient-centered world in the new mega rule, and also team conflicts. The nurse needs the resident to have their medications administered to them, while there's a scheduling conflict with the social service director or even the team in the rehab gym. So with that, there's an awful lot for the facility to administer regarding a resident and achieving their highest practicable well-being. Which medications are the resident using that would help them with their outlook, with their ability and willingness to perform, with their nutrition and chemical balance, and assure that they get the right sleep? And those are the questions posed today. So on the next slide, you'll see that the goals of pharmaceutical therapy and activities of daily living should be that a resident is pain-free, but without sedation, or they're fully awake and without constipation. That they're flexible, but they are also alert and without the GI upset that is almost always associated with some of the non-steroidal anti-inflammatories that our residents take for pain. There must be endurance to maximize the number of minutes assigned for that resident in rehab, and they have to endure without a loss of breath or without low blood pressure or without chest pain. How can medications promote these goals for that individual? Our residents should be continent of urine on the next slide, but without anticholinergic effects such as blurred vision or heart palpitations. They should be able to focus on the task at hand, but without oversedation from an anxiolytic if they are anxious about their condition, or the extrapyramidal side effects should an antipsychotic be administered to the resident. And yes, our residents must be mobile, but without falls or blurred vision that may be associated with muscle relaxants. So as we look at the next slide, the geriatric dilemma is that medications are almost always the mainstay of treatment in long-term care residents, and post-acute patients use multiple medications with an increased sensitivity to adverse drug reactions simply because they're post-traumatic, post-acute, or they are of an age where they become more sensitive to drugs. Medications, however, used properly, can enable residents to achieve a higher level of performance and learning capabilities while they're in rehab. And there must be dialogue between the consultant pharmacist and the therapist, as well as the rest of the interdisciplinary care team, to assure that adverse drug effects are not present and to assure that we are maximizing pharmaceutical care for all of our residents. Let's take this example on the next slide. A depressed resident is declining in ADLs and has really lost interest in personal hygiene. We might start out with a low-dose antidepressant to improve their mood and their willingness to participate in rehab services. It might take several weeks to see a positive effect, or at the wrong dose, we might see no improvement at all or even a loss of appetite. The consideration for a resident who's lost interest in rehab services is the evaluation of the medications. Do I have one that is causing depression? And if not, should we offer an antidepressant to promote well-being in this individual so they can maximize the benefit? Example 2 would be a resident with progressing heart failure is having difficulty in ambulation and stair climbing due to a shortness of breath and chest discomfort. their cardiovascular medications are successfully modified with the help of a pharmacist to increase with an increase in the potency of their diuretic. However, once they are on a walking program, the customer is interrupted for toileting. So let me pose this question to you. You have a resident that is in for cardiac rehab. They need some strengthening after spending so many days in the hospital. They come to you on furosemide or Lasix, 40 milligrams, which is administered at 8 a.m. in the morning sharp. However, their rehab appointment is for 9 a.m. I can assure you the only thing on the mind of that resident at 9 a.m. is, where is the bathroom, not how will I do at my appointment for rehab services. So it is not just the selection of medications, but it is also the timing of medications that will promote success in rehab therapy. One last example would be our COPD resident. When will we administer their bronchodilator? 20 minutes before they go to rehab, or wait until after they come back? What we want to do is schedule medications so the timing is at maximum potency or efficacy to allow our residents to assume the full benefit of rehab services and to stay in rehab for the full minutes allotted and even expand those to go ahead and improve their potential, their ability, and to be discharged from your facility after a very successful rehab services. So with that, I'd like to turn it back to Pamela so you can enjoy the rest of the program. And thank you for your attention.
Thanks so much, Nancy. That's great information. If anyone has questions that you'd like to direct to Nancy or any sort of pharmacy-related topics, you can go ahead and type them in right now. We'll address as many of those questions as we can at the end of the program. Now let's move into our main presentation by Cynthia Morton from NASL. So Cynthia, our audience is all yours.
Thank you, Pamela. It's a real pleasure to be with you today, especially in these last days, we believe, of the Congress as they rush to either get everything done or maybe not get everything done. And certainly there are some issues that are very important to our community that I'm going to talk about today. First, I just want to kind of give you a feel for my organization, National Association for the Support of Long-Term Care, NASL. We are an association of the ancillary services. You may see some logos there that you are familiar with. These are just a sample of our members. We work quite a bit in advocacy for rehab therapy, information technology, and diagnostics. So pretty much the ancillary services. I'm going to start today by talking a bit about Part B therapy, and Nancy gave us a wonderful introduction to this, especially with the study, with those results showing how beneficial rehab therapy is. And that's just a great lead-in. I'm going to talk about Part B to kind of set up what I want to say about therapy caps potentially being repealed this year or maybe into next year, and then talk about quality measures and some other things kind of on the horizon. So let me just set this up a little bit. Just to reset, where is Part B rehab therapy provided? Certainly for most of us on the audience in this call, you're with nursing facility settings, maybe home health, and certainly we know about rehab therapy, especially on the Part B side and the Part A side, provided in those settings, but it's the same Part B therapy, or paid for by Part B, I should say, is in other settings under the same policies that we're under in the nursing facility with respect to the therapy cap and such, which I'm going to talk about in a minute. Medicare spent $8 billion on outpatient Part B rehab therapy in 2015, and that was for 6 million Medicare beneficiaries. And I give you those figures to let you know that Part B rehab therapy is not an insignificant program somewhere that doesn't get much attention. We receive a lot of attention, and that's kind of why we have the therapy cap and why we have the threshold for medical review and other such policies. We are an $8 billion a year program, and Congress knows about us, and they are concerned that the spending is becoming too high, which I'm going to talk about more as we go. With respect to that pie chart you see there on the right-hand side of the slide, what I'm trying to show you there is between SNF, which is the blue, the kind of peacock blue slice on the right, 34% versus private office, 36% on the left. Those two slices of the pie, very, very similar in size. That is the bulk of where the Part B rehab therapy is provided. In some recent years, more Part B therapy is provided in nursing facilities and SNF than private office, and certainly in 2015 you see that private office provided more. So nursing facilities are increasingly a very popular spot where rehab therapy is provided, and our patients, as you could see from that study that Nancy outlined, are very much benefiting from it. But it has attracted a lot of attention by Congress, MedPAC, and of course CMS. So I'm going to go through kind of a quick history of where we've been with the therapy cap and related policies, because this will set the stage for me explaining where we're going to go. So BBA, Balanced Budget Act of 1997, was what put the therapy cap into law. 20 years ago, we got the therapy cap. There was, and you've probably heard of this before, there was no policy basis for Congress enacting a therapy cap. It was merely that they were writing policies that would cut the federal budget, cut federal spending, and Part B therapy was caught up in that, and there was a cap established, and as you know, two caps established actually, at $1,500. No rhyme or reason. And we've been fighting that therapy cap on behalf of our patients ever since. In 2006, thankfully, Congress enacted an exceptions process. As you well know, it's kind of like an appeals process for patients who need medically necessary therapy beyond that cap. Then in 2011, we had some dark years with CMS imposing that MPPR. You maybe have heard that acronym that stands for the Multiple Procedure Payment Reduction. That was not unique to therapy. Congress got into the act in 2013 and increased it to 50%. But CMS saw that as a winner. They saw it as a policy that they could extend to other sectors. Imaging, radiology was also subject to MPPR. What does that mean? It means that CMS saw that there's efficiencies when one particular service off the fee schedule is provided multiple times to the same patient on the same day. So you can see how imaging, x-rays, could get caught up in that. And it was successful, I call it, for CMS because they were able to cut. That 25% and the 50% is a cut of the CPT code. So it was not a 20% cut of the overall service. It was a cut to the portion. Thankfully, we've not seen more MPPR cuts in the therapy sector or in other sectors, and I hope that CMS and Congress feel like they've kind of gotten all they can out of that policy and kind of moved on to other. So in 2012, we had a law, Middle Class Tax Relief and Job Creation Act of 2012, some people call it Matricia, signed into law in February 2012. That imposed manual medical review. I'm sure many of you who are very involved with the rehab therapy in your nursing facilities know exactly what I'm talking about. And I think you would probably agree with me that CMS's implementation of manual medical review, wasn't it around September, October of 2012, was a disaster. It was a nightmare, and I don't use those words lightly. All claims, the law said that all claims above $3,700 needed a review for medical necessity. Why did Congress enact that? They enacted that because, back to why I showed you on that first slide or second slide, why Medicare spent $8 billion, a number which has been steadily increasing. Medicare spent $8 billion on Part B therapy in 2015 alone, a bulk of it being provided in SNF and outpatient private office. CMS, Congress, especially Congress, were concerned about that increasing spending, increasing trajectory, and they put a kind of a lock on it. They said, okay, at $3,700, when the claims hit that amount, we're going to want to have a medical necessity review. And in effect, they're trying to slow down the spending, okay? They're trying to slow us down. And unfortunately, as I mentioned, the implementation of that was a real problem for everyone involved. The MACs were just not ready to conduct those therapy reviews. They weren't ready for the volume. So that was really tough. And my organization, along with other therapy organizations, we did a lot of talking with CMS, a lot of lobbying of Congress and MedPAC, and trying to explain why this was such a problem. And thankfully, come 2015, in the MACRA law, which was a huge law, and for those of you that watch these things this closely, that was repeal of the SGR doc cut problem. We were able to get language into that new law that targeted medical review, prohibited RACs from conducting the review, and the main change there was that not all claims above $3,700 have to be reviewed, but targeted claims above $3,700 are to be reviewed. So not all claims. It reduced the volume. It allowed CMS to act smarter and not having to do review of every claim, which was not working and not worth the effort. So currently, we went through a lot of tough times with that, but just to kind of fast forward to where we are now, CMS has moved the review of those claims to a SMRC, as I call it, a supplemental medical review contractor. And the contractor CMS is working with is called Strategic Health Solutions. You see that on the second bullet there. And according to the CMS website, the review for some claims, the review of some claims above $3,700, and as many of you know, there's actually two review thresholds, as we call it. When PT and SLP claims get above $3,700, there's a targeted review of those claims, and then a separate medical review threshold for occupational therapy claims. They're parallel with the way the CAP works. The way they're looking at these claims, and it's up and down geographically around the country, but they look at providers with a high percentage of patients receiving therapy beyond the threshold as compared to their peers. They're looking at therapy provided in SNFs and private practice specifically, and that's another reason why I showed you that pie chart at the beginning of the presentation, to show you that's where the bulk of the Part B therapy is being provided. So it makes sense that CMS would have their contractor, unfortunately, but it does make sense to concentrate review in those two settings. Now, the next words in that second bullet don't make a whole lot of sense. You might be reading them thinking, "Oh, she made a mistake there," but I actually took these bullets directly off of the CMS website, and we don't really know exactly what they mean. I'll read it here. It says, "Therapists in private practice and outpatient physical therapy or speech-language pathology providers, parens, OPTs, close parens, or other rehab providers." CMS has never really corrected that. We don't know exactly what they mean, and they've not really dialogued with us in that area to kind of clean that up. Perhaps if we get some movement in Congress on kind of the next generation of therapy cap policy, we'll be able to clean that up a little bit. But that's where I have to say, from the rehab therapy companies I represent the majority of them, we're not hearing complaints from the field that this is going poorly. All in all, I hear pretty good comments. So I guess in some ways, no news is good news. So let's see. Let's go to the next slide here. Where we are now, we've got a therapy cap amount that's been, and perhaps you could advance to the next slide. We've got a therapy cap amount that's been finalized in the physician fee schedule for 2018. The amount is $2,010. And this is the part we want to focus on now. Okay, now we're really going to get into the meat of what I want to talk about. We have a exceptions process that is currently authorized through December 31st, 2017. Yikes, just in a few days that is going to expire, right? And that was authorized in the MACRA law, the same law that gave us the targeted medical review above the thresholds. So we've been living under that exceptions process. It expires in a few days. So gee, what is going to happen, okay? And that's really what I want to talk about here. So let's get into that. There's several scenarios of where we can go, and it's really Congress with the reins here. Congress has been working on repealing the therapy cap, and I'm going to explain that policy in a second. Congress can pass that legislative text that they've written. I'm going to explain it in a minute. They can do that. Congress could, and we'd like them to do that, Congress could also reauthorize our exceptions process, extend it a couple more weeks, get us into January. I'm going to talk about that in a minute. They could authorize it like they've been doing, over the last 15 years or so, extend it another year or two. Or Congress could delay. They could not touch our exceptions process and let the end of the year happen, and we could go into January with a therapy cap for our patients, which would not be good, would it? So I'm going to explain all that, but I just wanted to give you kind of the range of some possibilities. So let's get back to the bright side. The good news is that Congress, and more specifically, the Committee of Six, the Group of Six, which I'll explain who they are in a minute, these are a group of committee staffers from the three healthcare committees in the Congress. We've got the Senate, to outline the three, we've got the Senate Finance Committee. The Finance Committee has jurisdiction on the Medicaid and Medicare program. Then on the House side, we've got two committees that are involved in this negotiation. The Energy and Commerce Committee, which primarily they have Medicaid program jurisdiction and a little bit of Medicare Part B. And then we've got the almighty House Ways and Means Committee, which has Part A, Medicare Part A jurisdiction, and a little bit of Part B jurisdiction. So all three of these committees have jurisdiction over Medicare Part B. So that means all three of them have the authorization in Congress to write bills and consider bills on our Part B rehab therapy outpatient therapy cap. Two staff from each of those committees have been working on this policy. And I keep saying two staff because that means what was happening here is you had one Democrat committee staffer and one Republican committee staffer. And so you had that pair from each of these three committees. 2 times 3 is 6. So that was this kind of group of 6. They've been working on these therapy cap repeal policies for several months. So because we've got the Senate committee and 2 House committees, and we've got Republican and Democrat, this is actually a bicameral, bipartisan effort, which you don't see that often. But really, I mean, we find, and I've been a healthcare lobbyist for almost 20 years here in Congress, healthcare issues are generally bipartisan. With the exception of maybe the Affordable Care Act, you don't really get into Republican or Democratic healthcare issues. So it makes sense that they've been working together, and it's been really efficient that they've been working together. So on October 26th, these healthcare staffers, the healthcare committee staffers, announced that they had agreed upon a discussion draft language that would repeal the therapy cap, yay, and continue medical review in its place. So you're saying, wait a minute, they're going to continue medical review. We don't really want that medical review, do we? We just want to repeal the therapy cap and kind of go on about our business, providing this good rehab therapy that gets good outcomes, right? Well, we're going to have medical review with us, really, I would predict, for the lifetime of rehab therapy and providing rehab therapy. This goes back again to why I showed you that first slide with the pie chart and specifically with the $8 billion number. There are a lot of dollars flowing to rehab therapy, to nursing facilities, to private practice, for Part B therapy, and Congress, CMS, they want to keep some kind of control over that. So we're going to have medical review for a while. So I'm going to explain this a little bit more in a second. But I wanted to kind of give you the context for the agreement for this language. So for those of you thinking, gee, Congress really doesn't do anything, actually they do. They do a few things, and they've worked really hard on this policy. So let's go into some more of the specifics of really what this means. The discussion draft language that the committee staffers agreed upon on behalf of their bosses, the members of Congress on those committees, and the language that was presented to NASL and other members of the Therapy Cap Coalition, that language would repeal the therapy cap as of January 1, 2018. No more therapy cap, period. That language would also continue the requirement to put the KX modifier indicating services are medically necessary above this $2,010 amount as well. That's a policy that's in place now, and that would be continued. Also, that, as I stated, that medical review process, reviewing claims above a claim dollar threshold would also be continued, but would be altered a little bit. The threshold for medical review would be lowered to $3,000. As you know, it's currently at $3,700, but it would be lowered to $3,000, and as we have now, there would be really two review thresholds. There would be a $3,000 review threshold for physical therapy and speech-language pathology claims, and a separate $3,000 review threshold for occupational therapy claims. Now, admittedly, lowering this dollar amount threshold is going to have more exposure for patients in the therapy provided in the nursing facility setting. We're going to have more exposure there for more reviews because we're providing more of that higher dollar level therapy because our patients have a higher acuity and tend to require more therapy. But that is just kind of a part of accepting that we're going to be able to repeal the cap, or actually that Congress, hopefully, fingers crossed, is going to be able to repeal the cap. So let me back up a step and kind of give you some greater context for what's remaining in Congress. Are they going to be able to repeal this therapy cap? When are they going to be able to do it? What is it going to take? We had hoped as advocacy organizations that the fact that the committees revealed that they had come to agreement on this discussion draft back at the end of October, that would mean maybe we, or really Congress, could get this done this calendar year, because we know that the exceptions process is about to expire, and that would be it would work out very conveniently if we could get the cap to be repealed as of January 1, 2018. But we are getting close to the end of the year, and we do believe that Congress is most likely going to be finishing up come this Friday, the 22nd, or maybe Saturday, the 23rd. For those of you that have heard my presentations, I always like to tell my audience that Congress works best on a deadline, and holidays are a deadline. They do want to get home to their families. And Christmas Eve is Sunday? So they're going to want to be getting home Friday night, Saturday. So Congress could be finishing up this Friday. They are practically done on the tax reform that they want to do. The deal has been struck, and they're going to be voting on that today. That'll be a big task they'll get off the list probably today, maybe into tomorrow. CHIP, Children's Health Insurance Program. That needs reauthorization. Congress has been working on that for months. They blew through their deadline, I think it was September, to do that, and states are now running out of CHIP money. And there's a lot of pressure on Congress to get that done, and that's kind of in the mix, possibly, maybe even by Friday. Most important is something called a continuing resolution. This is what's funding the government right now. When you hear the government is going to stop, that's what they're referring to. If Congress Congress right now is under a continuing resolution that funds the government through this Friday, the 22nd. If Congress does not act to extend that to maybe January, or just pass all their funding bills this Friday, which they could do, just not sure, then we wouldn't have a shutdown. But we're hearing that maybe they'll extend the current funding of the government to January 19th. And so that might continue all these policies until that time. But that is a big thing that Congress does need to do this Friday. And I'm getting ahead of myself. Let me explain the budget caps here real quick. You may hear a little bit about this issue, budget caps. You might hear it explained as spending caps. This is a big negotiation that's really going on at a very high level in Congress with leadership, and it's all about how much spending was authorized a couple years ago through an agreement, and whether Congress needs to exceed those spending caps. But most importantly, if they exceed those spending caps, are they going to want to offset, or in other words, pay for the fact that they're exceeding their spending caps? And if they do that, I know you're saying, I don't know what she's really talking about. What does it mean for me? If they decide to pay for or offset a portion of those spending caps, they are looking at asking the Medicare program, specifically providers, to bear the burden of paying for some of that. And we could see that 2% sequester extended. More to come on that. The bottom line of me really showing you this kind of list of this agenda here for Congress in these waning days is that our therapy cap repeal, which is one of the so-called Medicare extenders, could be attached in any of these big bills that we think could be acted upon by Friday, or if Congress does not act by Friday and instead kind of punts to January, then we, the Therapy Cap Coalition, are asking Congress to, hey, we're saying you got to extend our exceptions process at least till January, till we can get into a position again where Congress is looking at repealing the Therapy Cap policy again. Congress very much wants to repeal the therapy cap. It's really all about how they can identify offsets or ways to pay for it. Why do I keep talking about offsets all the time? This is very important, and I kind of draw your attention to that second bullet here. And if there's only a couple takeaways that you get from this presentation, this ought to be one of them. Congress is acting on a self-imposed rule that any policy that they want to pass in a bill that causes money to be spent by the federal government, Congress wants to, their rule is that Congress has to offset or find a cut in spending somewhere that pays for that new spending. Repealing the therapy cap, even putting in a program, continuing the program of medical review, even lowering that threshold of medical review to $3,000, that policy costs the federal government more money because more therapy most likely will be provided than otherwise would have been. And so Congress wants that, they're going to pass that policy. They want to offset it. So along with the therapy cap repeal in the bill that it eventually will be placed into, there will be offsets that pay for it. Where are those offsets going to come from? Well, Congress is right now negotiating offsets, or pay-fors, we kind of call them, in the SNF sector, in the home health sector. So it's very, very, very possible that nursing facilities on the Part A side could see cuts maybe to the market basket. That is our payment update we get every year. Home health could see cuts to the market basket, the payment update they receive every year that helps pay for this therapy cap repeal. A lot of words on this slide, and I'm going to move ahead a little bit because I want to leave time for any questions that we're going to have. But this gives you kind of a feel for all these, quote, extender policies that that Congress wants to extend along with the therapy cap repeal. And the therapy cap repeal is the third bullet there. Really should have it at the top because it's the biggest policy in terms of dollar amount. The repeal of the therapy cap policy, we've had informal scores by the CBO that say it could cost the federal government between $6 and $8 billion over $6 to $12 billion over 10 years. So Congress is having a hard time really finding other cuts to offset that. And my next slide gives you just a couple of, there's some very kind of vague terms here on this slide, and that's because Congress has not announced or revealed what the exact cuts or offsets are going to be to offset the extender policies, including the therapy cap. And Congress is not going to reveal that until kind of the last minute, because if you're in this area where you're getting cut, you're going to fight it, right? If you didn't agree to it. So you can see how strategically Congress or the various committees would not reveal what those cuts are going to be until they're really ready to move the legislation. So everything could really happen Thursday night into Friday, but I'm getting really concerned about it because here we are on Tuesday, and we know Congress wants to leave town, most likely Friday, maybe Saturday, and we're not really hearing much about the extender policies moving. Now, it could be because Congress is very focused on getting that tax reform done. They're trying to deliver a huge accomplishment. So we could see the extenders legislation that would include the therapy cap repeal and some SNF and home health offsets. That could happen Friday. If it doesn't, then it's going to, unfortunately, go into January. And if Congress doesn't give us a little mini extension of our exceptions process into January, that therapy cap will go into place January 1. So, watch this space very carefully. Let me hit a couple other areas that I want to hit before we're done here. A couple other big ticket items happening, right? We've got RCS1. CMS issued the advance notice, the proposed rulemaking, letting us know, hey, nursing home stakeholder community, we're thinking about a major payment model change, and we could propose that next year in 2018. We're thinking, around the April-May time frame, perhaps. That's around the time frame of our, when we usually get our annual payment rule. And I'm sure there'll be a comment period. CMS received more than 260 comments on the RCS1, and they are working through those comments and making potential changes to RCS1, and we will see what pops out in 2018. And it's possible that Congress could have something to say about that in any final legislation this year. So we've got RCS1, which I'll have more to say in a second. We've got the Impact Act, which covers not just nursing facility, but the other three post-acute care settings, continuing the march to many, many, many quality measures. We've got a couple on the horizon: medication reconciliation and transfer of health information. Right now, we're under a couple of. Nursing facilities have been submitting data on three measures: patients with pressure ulcers, residents experiencing one or more major falls, the admission and discharge functional assessment. They've been submitting data on that for 2018. For 2018, in May of 2018, CMS has got a deadline for the data collection for 2017 data that is going to be submitted off your MDS that will affect the APU or the payment update. You could lose 2% in 2018 if you've not been submitting 80% or 100% of 80% of your MDS for these measures. So we've got some real kind of rubber hitting the road in terms of the deduction from your payment update per facility if you're not complying with the data collection requirements. And this will only continue. It's a shame there's such a lag between the data submission by the facilities and the payment deduction. And I think CMS may, improve that as time goes on. But because our time is short, I'm going to move quickly. We're just really at the beginning of many of these quality measures, and they're really going to continue. A little more detail on RCS1. It's really been a big deal in the nursing facility sector. It's very different than the current RUG system we're on. The reimbursement pay is going to be based on patient characteristics, not provision of services. Therapy, rehab therapy will not, and we're of course talking Part A here, therapy is not going to drive the payment categories. The payment is still going to be, if they go forward with the way they outlined it, okay, in the advance notice, and there will be tweaks, I'm pretty sure, but I'm just basing this on what we saw in the advance notice. We're still in a per diem, okay, because CMS is undertaking this payment reform on their current statutory authority. Congress did not tell them to do this, so they have to use their current authority, and their current authority is a per diem. So it's not episodic, okay? It's nothing, kind of like the future. It's a per diem, and that per diem is based on 5 payment components. How a patient kind of works their way through the PT and OT patient characteristics. There's an SLP payment, a non-therapy ancillary payment, a nursing payment, which is essentially the current RUG system, and then non-case mix. Each of those 5 components, actually not non-case mix, but the first 4, each of those 4 components has its own grouping process using different variables and scoring methodologies. Another takeaway from this presentation, if you just get a couple things, I really want to impress upon you that all current outcome measures still apply. There's been a lot of talk in the nursing facility sector that when CMS moves to this new RCS1, and it stands for Resident Classification System, there's been a lot of chatter that a patient, and this is true, a patient could be categorized for a PT-OT payment, and that could be part of the per diem, but there does not seem, at least in the payment model that's been outlined in the advance notice, that there does not seem to be a requirement that therapy be provided. And so there's been some chatter that providers might be paid for therapy but not provide it. I really want to impress upon the folks on the line here that all the current outcome measures still apply, meaning just let's take, for example, the functional assessment measure coming out of the IMPACT Act. Right now it's just a process measure, but it will become an outcome measure soon enough, and those still apply. Nursing facility operators still have to show outcomes and that our patients are improving. So it's this payment model that CMS has come out with has some big worries in it, for sure. But let's wait and see what CMS comes out with, because I think they're going to be making some tweaks in that area. Wow, I've laid a lot on you here. Let me talk about Medicaid a little bit because I've had so much emphasis on Medicare. Let's go back to the beginning of this year. Remember repeal and replace, the big effort when at the beginning of the Trump administration and in the new Congress really focused on repeal and replace. And, nursing facilities didn't exactly have a dog in that fight in the repeal and replace of the Affordable Care Act, but where we were really involved was the part of repealing and replacing the Affordable Care Act that reformed Medicaid. And the nexus to the Medicaid program was that part of Obamacare makes Medicaid a part of the insurance equation, right? Childless adults were able to be eligible for Medicaid in the states that chose to expand their Medicaid program, and that was a way to get more people insured. Okay, and those weren't people in our nursing facilities, right? They were adults, childless, adults out there working. Well, but that I'm just explaining that was the connection for Congress to use the potential repeal of Obamacare to reform the entire Medicaid program. And the way Congress wanted to do it is they wanted to convert the financing that comes out of the federal government and is given to the states. They wanted to convert that instead of just this free flow of entitlement dollars. They wanted to convert that to a per capita cap flow of dollars, or a block grant. Per capita cap just means that there would be a specific dollar amount allotted per Medicaid beneficiary in a state. And that was converting that financing extremely controversial. Many of the nursing facility sector opposed it, okay? And it went on for a couple of months. It did not happen. But we do believe that Congress could come back to that in 2018. That's on the Medicaid side. And then just recently, Speaker Paul Ryan recently stated he wants to pursue Medicare and or entitlement reform in 2018. You know, you hear that phrase, entitlement reform. What does that mean? The entitlement programs include Medicaid, Medicare, and Social Security. And often lawmakers, politicians don't want to touch Social Security. They don't want to cut it, right? Because they're afraid of a backlash during the election time, and so they kind of call it the third rail sometimes, and so they don't touch it. So we could see a focus, and this is kind of where I'm going to be ending the presentation, and we'll go into Q&A in a minute. The big question is, will the leaders in Congress who talk about kind of getting back to cutting these entitlement programs because they feel like they are consuming our federal budget, will they, get back to looking at per capita caps or block grants for Medicaid, or finding very dramatic ways to cut Medicare? Will they do that, as they're saying they might, into 2018? Or will, because it's an election year, will they not want to touch those programs? That is a big, big question. So I like to say buckle your seatbelts because it could be a wild year. We could be facing RCS1 or changes to it specifically for the nursing facility sector in April, May, and at the same time in Congress trying to fight or at least try to make changes to large-scale financing changes overall to the Medicaid and Medicare programs. So it's going to be a pretty big time next year, and you're going to really want to watch and stay close to your advocacy organizations. We'll be communicating what's happening in real time. So at that point, I will hand it over to Pamela, who I think is going to help me conduct our Q&A.
Great, thanks so much. So many balls in the air, and a lot of it's got to happen in just the next week or two. We've already had some questions come in from the audience. I just want to remind everyone that you can submit a question right now using the Q&A button below the slides, and let us know what you want to hear about. One of the questions we have is, and I think we could just sort of extend to your expertise, what are your thoughts about whether the RCS1 will actually go into effect in 2018?
Yeah, that's
in your professional opinion, sort of what are the things going into the chances of that actually going into effect next year?
Okay, so let's think about it. First, I'll start externally. MedPAC, it's an advisory body to Congress. They advise Congress on the Medicare program, specifically providers, profit margin, that kind of thing. MedPAC has been putting a lot of pressure on CMS to come out with a new payment system. Okay, CMS, they are a bureaucracy. They have set down this path of proposing to our community, hey, here's the payment model we're thinking about based on the research we did with Acumen. We want your comments. they held open the comment period for another 60 days, right? They've even gone to great lengths on some of those open door forum calls to say we still have a email address out there to receive comments. Now, internally, so as a bureaucracy, they're going to keep marching to what they've said they're going to do. They've said that on the open door forum calls that they are looking at all the comments that they received and trying to make changes to RCS1 based on those comments. But CMS is run by new leaders. We've got Seema Verma, who's come in, the Trump appointee. She has Medicaid expertise. Certainly her focus has been on that Medicaid reform and repeal and replace earlier this year. And now she has this huge program that she's out there working on reducing regulatory burden. So it's very hard to tell. Will she want to keep that payment model moving? I mean, I think there is a good probability that it will be proposed in the year. We don't know if we do not know if Congress will have something to say about it in this end of the year, whatever end of the year legislation we may get by Friday, or if it gets breaks down and instead we get it in January. And why I keep saying that is because Congress could tell CMS to propose a new payment system and give some details about how they want it to happen. And if Congress says we want it to happen in this way and we want to get X amount of savings out of it, those savings accrue to Congress, which allows Congress to use them as offsets for, say, therapy cap repeal or other programs that they're under pressure right now to pass and pay for. So kind of a long answer there, Pamela, but I think it's very
financial
possible.
Musical chairs in a way.
Yes.
Okay. We've had several questions kind of about this topic, so I'm going to sort of try to summarize all of the questions together in one. It's about the targeted, that sort of targeted
medical
claim.
review.
Right. So let's assume, for the sake of the question, that we stick with the language we have now, and we're not reviewing all the claims, we're reviewing targeted claims. Could you talk in a bit more detail about what are sort of the things that constitute a targeted claim specifically in the skilled nursing environment? Is it percentage of denials? What are the things that go into getting a claim flagged as a targeted claim?
We don't have a huge window into how Strategic Health Solutions is handling it, and that's probably why I verbatim put on that slide those 3 bullet points. We know that they're specifically just looking at our setting, I mean the skilled nursing facility, but they are looking at a lot of therapy, and I know a lot is not a very clinical term, provided to one patient. They're questioning the amount of therapy. They also are looking at new providers that have recently enrolled in the program, but that's going to be a limited amount of providers. And they're looking at the number of units of hours of therapy provided in one day. And I'm sorry, but beyond that, we really don't know much more. That's about all we know.
Still kind of hazy.
Yes. And let's look on the bright side. Let's say Congress is able to repeal that therapy cap and enact that discussion draft language by Friday is our best case scenario, but they're able to do it, say, maybe by January 19th. Once CMS, if all goes to plan, if this works and CMS gets that directive, the therapy community will work very closely with CMS to help go to a very smooth, continue this smooth targeted review of claims. In fact, I think there might be some language that says CMS has to do it by notice and comment, which means the formal regulatory process, instead of just what they've done in the past, is slapping some bullets up on a website, and that'll give us a chance to have more impact on how that medical review is handled by a contractor. But that's if all goes to plan, and sometimes things don't happen that way with Congress. Sometimes it just takes a while.
All right. Unfortunately, that's all the time we have for questions today. Thanks again, Cynthia and Nancy, for such an informative presentation. We have some final instructions regarding the CE credits for this presentation. Please don't leave the site right now. Stay right here on this platform, and you will be automatically redirected to the CE certificate at the conclusion of this presentation. For those watching in a group, just a reminder, please download the group submission guide in the Resources tab to the right of your screen and follow the instructions you find there. And just to note again, today's CE credit is not available for the archived version of this webinar. It's only available for the live event today, December 19, 2017. So I want to thank Cynthia Morton and Nancy Losman again for such an excellent bunch of information to give to us today. And I'd like to thank our program sponsor, Omnicare, for making today's program possible. And finally, thanks to you and our audience for participating with us today. We hope you'll join us in the future for another IASC webinar. And this concludes today's presentation.